Welcome to IPOPI Hard Talks. My name is Martine Pergent. I am the president of IPOPI, and it is my pleasure to co-moderate this digital event with Dr. Nizar Mahlaoui. Hello, Nizar.
Hello, Martine. Hello, everyone. I'm Dr. Mahlaoui. I'm a pediatrician here at the Necker Hospital in Paris, and I'm the chair of the IPOPI Medical Advisory Panel. And I'm very glad to co-moderate this event with you, Martine.
First, let me take a moment to thank our sponsor, CSL Behring, for making this event possible. Before we start, let me remind you the IPOPI Hard Talks concept. With IPOPI Hard Talks, we explore the complexity of our field with the help of two experts, a presenter and a challenger, who will both bring different perspectives. The presenter will give a talk, after which the challenger will open a stimulating debate. The theme today is clinical application of calculated globulin screening. To engage in this discussion, I am delighted to welcome our challenger today, Professor Stephen Jolles from UK. Professor Stephen Jolles, you are a consultant clinical immunologist and honorary professor at the University Hospital of Wales and Noah's Ark Children's Hospital of Wales, for Wales. You are clinical lead in the Immunodeficiency Centre of Wales and co-director of the Hub Immunology Diagnostic Laboratory of Wales and adult clinical lead of the SWAN, Syndrome Without a Name, clinic. Welcome and thank you.
I'm very pleased to introduce our presenter today for this webinar, Dr. Cecilia Poli from Chile. Dr. Poli, you're the director of the program of immunogenetics and translational immunology called Pergent at the Institute of Science and Innovation in Medicine at the Universidad del Desarrollo, Santiago, Chile. You train in pediatrics, rheumatology, and immunology at the University of Chile and earned a PhD in immunology at Baylor College of Medicine in the US, working with Dr. Jordan Orange's laboratory. Upon returning to Chile, you founded a diagnostic lab and initiated a research program focused on primary immunodeficiency. We are very much honored to have you today. Thank you and welcome.
Welcome of you. How will this hard talk work? Dr. Poli will give a lecture. After the lecture, Professor Jolles will share his comments, and together they will discuss and debate this topic. During the presentation and the discussion between our two guests, you will be able to send written questions in the question tab. So let's begin. Dr. Poli, the floor is yours.
Thank you very much. Thank you for the kind introduction and for the invitation to be here today. So we're going to talk about the clinical application of calculated globulin as a screening test. So what is calculated globulin? Calculated globulin is a very simple calculation between the total proteins in which we subtract the albumin and then we get the calculated globulin value. This is generally present when you order a liver function test or in our setting, the biochemistry lab. So we have the calculated globulin here. Calculated globulin can be used as a screening test for antibody deficiencies. This is very relevant because antibody deficiencies are the most common form of primary immunodeficiency worldwide. It's estimated prevalence between 1 in 25,000 people. And the problem with this immunodeficiency is that there is a great diagnostic delay between 6 to 7 years, especially in adults. Also, secondary immunodeficiencies are on the rise because of the increased use of immunosuppressive therapies. Early detection in these patients is crucial to prevent irreversible organ damage. And although a lot of countries in the US and in Europe now have newborn screening available for the screening of primary immunodeficiencies, this is only suitable for SCID patients, but it's not suitable for CVID patients or other forms of antibody deficiency that may manifest in life later. Also, this will not detect patients with secondary immunodeficiency that are becoming more and more prevalent. So, calculated globulin reflects the immunoglobulin-rich gamma globulin fraction. in the proteins that are present in the plasma. A low calculated globulin indicates possible hypogammaglobulinemia. It meets the WHO screening principles because this is an important condition, right, that can cause high morbidity and mortality. It has defined markers such as the levels of IgG, IgA, IgM. The cutoffs are validated, and there is an effective therapy with immunoglobulin infusions. The advantage of this test is that it's very inexpensive. It is widely used. It is determined in a lot of patients for many reasons in primary care, and it's therefore suitable for large-scale implementation. The calculated globulin levels correlate with IgG levels in the serum. As you can see here, there is a spread, but generally at lower calculated globulin levels, there's going to be lower IgG levels. And this is from a study from 2014 from Dr. Jolles, in which they described that calculated globulins below 18 grams per liter correlates with an IgG below 6 grams per liter, which is what is considered abnormal for adults, using the bromocresol green method. And this was true for 89% of the samples. They determined the sensitivity of 0.82 and a specificity of 0.71. In 1.2% of the samples, interestingly, they found previously undetected paraproteins with immune paresis. So also screening for this paraprotein presence is important, and these patients are also at risk of immune deficiency. In the other method, the cutoff is a little bit higher, 23 grams per liter, also with good sensitivity and specificity, a little bit lower than the bromocresol green method. Hematology patients have the highest yield of being detected with lower calculated globulins and therefore lower immunoglobulin. Patients had lymphoma, CLL, myeloma, and amyloidosis. In primary care, calculated globulin also flagged unrecognized antibody deficiencies in patients that were on immunosuppressants or with chronic illnesses. These are patients that are regularly seen in outpatient clinics and are not necessarily tested for immune deficiency or hypogammaglobulinemia. Some of these referrals actually led in this work from Dr. Jolles to new PID diagnosis and timely immunoglobulin replacement. They did something really interesting that has been replicated thereafter, is that they tracked one of the patients that they diagnosed with CVID and looked at the past calculated globulins of these patients. And already 3.5 years before this patient was diagnosed, already the calculated globulin was low. So we could have detected this patient 3.5 years earlier, avoiding complications. So thereafter, since Dr. Jolles published this study, there have been a number of studies worldwide that have validated the use of calculated globulin as a screening test for antibody deficiency, mostly in the adult population. But interestingly, the group of Dr. Condino also validated this test for children and adolescents, which is a group in which IgG levels are more variable. What they did is that they collected patients below 18 years of age, divided them in different groups, so below 1 year, below 4 years, below 10 years, and from 10 to 18. And they used the IgG cutoff values depending on the age. So they consider hypogam below 1.5 gram per liters in the patients that were younger than a year of age, below 3.2 for those patients that were between a year and 4 years of age, below 5 for those patients between 4 and 10 years of age, and as they had done for adults before, below 6 grams per liter for patients between 10 to 18 years. So they instead of classifying patients all below a threshold of IgG levels, they classified these patients below a threshold that was corresponding to their age group. And what they found is that they could determine an AUC for all of these groups, and with a very good sensitivity and specificity for the use of calculated globulin, even in these pediatric age groups, as long as we compare them with the appropriate cutoff levels for immunoglobulin at their specific ages. Um, so it cannot only be used in adults, but also in children. This is our experience in Chile, which is relatively new. We've just started doing this in Chile. We've screened almost 30,000 samples. Of those, 260 samples have had a below 1.8 grams per deciliter of calculated globulin. And because we need to match these patients with only those that have also a serum tube where we can determine IgG, IgA, and IgM levels. We had to exclude patients that didn't have a second tube, so we ended up so far with 35 patients, and we've observed pretty much the same. 23 of these 35 patients had hypogammaglobulinemia, defined as below 600 milligrams per deciliter, which corresponds to 65.7% of the patients that had low calculated globulin. So these results, although we don't have still the N that we require to demonstrate it, and we're working on it, are in line with what has been published before, and we could also implement calculated globulin in our system. Calculated globulin can improve early detection of CVID, and this is a very interesting data that was presented in an abstract at CIS meeting this year, in which LabCorp retrospectively screened 28,000 patients that had both albumin and total protein results. They found that most of the patients that had a calculated globulin over 1.8 grams per deciliter had normal immunoglobulins, whereas only 35.4 patients who had low calculated globulins had normal immunoglobulins. So, meaning that this cutoff level of 1.8 or 18 grams uh, is also true in this large scale screening population. Interestingly, they identified 3,426 patients that had CVID as an ICD-10 code on one of the tests, and they tracked these patients to the calculated globulin levels that they had before this diagnosis was made. And they identified that these patients had low calculated globulin levels even 3 years before the diagnosis, underscoring the utility of this test as a very good screening test. And interestingly, this 3-year cutoff is very similar to what Dr. Jolles had found in his cohort in 2014. So we can make an early diagnosis almost by 3 years with using this calculated globulin test before the patient even starts having a recurrent infections or complications. There are some problems, though, with the calculated globulin. We have to remember that as a screening test, it is non-specific, and multiple diseases can affect calculated globulin. It may mask changes when albumin is falsely high or low, and it is, of course, not to be substituted for the immunoglobulin quantitation. If we look here at patients that have very normal IgG levels, some of these patients, for different reasons, can have low calculated globulin levels. So there is a huge spread. Whereas if we look at patients here below the 6 grams per liter cutoff that is considered the normal IgG levels for adults, there are patients in this range or even lower that have normal or over 1.8 grams per deciliter of calculated globulin. So it is not so specific, and we do have to consider that there is a spread, but as it has been demonstrated for both children and adults, it is a good screening test that can detect most of patients with hypogammaglobulinemia at an early stage. Calculated globulin, it can also be used when we detect high calculated globulins. This has been associated to paraprotein presence and especially important in multiple myeloma. Multiple myeloma is the second most common hematological cancer. It represents 1% of all cancers. And the global incidence has greatly increased in the last 10 years. Diagnosis is also delayed because the symptoms are not specific, such as back pain or fatigue, and the early diagnosis is key to improve survival and reduce complications. In this study of multiple myeloma patients, they recruited 109 patients, and they found that 83% of the patients with active multiple myeloma had an elevated calculated globulin. Smoldering multiple myeloma patients, 73% had elevated calculated globulin. So it is very useful to detect these patients. The patients with free light chain multiple myeloma have no paraprotein, so they tend to have more low calculated globulin in 30% of the patients due to immune suppression that is often present in these patients. So we can also detect immune suppression in these patients with multiple myeloma, and these patients may be needing immunoglobulin replacement to control infections or prevent them. Um, Also, in this work, they found that 41% of patients with multiple myeloma or smoldering multiple myeloma had calculating globulins over 39 grams per liter, 15 months prior to diagnosis, also highlighting the utility of this test as a screening test, not only for hypogammaglobulinemia, but for multiple myeloma and other sources of paraprotein as well. Some multiple myeloma had normal calculated globulin, and this may be because some patients were in immunosuppressive therapy, so the IgG maybe was lower, and this was counterbalancing the size of the paraprotein. Therefore, we were not detecting the high calculated globulin. So, as with hypogammaglobulinemia, there's also a spread, but this can be used as a screening test or as a flag to detect these patients early. It is not, though, a very good test, as I mentioned, for the free light chain multiple myeloma because these patients do not tend to have paraprotein, so they tend to have more lower calculated globulins than higher calculated globulins. But not all patients have lower calculated globulins, so they may not be detected with this test. So elevated calculated globulin can also be a biomarker of other conditions such as liver disease, hematological malignancy, autoimmune disease, and importantly, infections. And I want to stop there for a moment because HIV is very relevant in primary care settings, and these patients can also have high calculated globulins because they tend to have very high IgGs at the beginning. So this can also be important to flag these patients in a primary care healthcare setting and study them further to see what is the cause of this elevated calculated globulin. I found this study from this year that I found really, really interesting. This is a study from a group in China that they screened 23,000 patients in the ICU and looked at their calculated globulins. And what they observed is that the mortality in the first 28 days in the ICU in patients that were admitted for sepsis decreased markedly for every degree in that the calculated globulin was higher, up to 2.9 grams per deciliter, where this curve plateaued. So for every gram per deciliter that the calculated globulin increased, the probability of mortality in the first 28 days of patients in the ICU due to sepsis decreased significantly. I found this very interesting because patients in the ICU are getting a liver function test or biochemistry labs almost daily or every other day. So I found very interesting that we could use something as simple as the calculated globulin to detect the risk for mortality. This can be due to immunosuppression that is predisposing them to infection in this period, or also as as an impaired acute phase response that is impairing their whole immune system to respond adequately, and therefore they tend to have more complications. So, in conclusion, calculated globulin is an underused, very inexpensive screening marker that we usually have at hand. Low calculated globulin has to be considered immunodeficiency or protein loss. And when we have high calculated globulins, we have to suspect chronic inflammation or monoclonal disorders such as multiple myeloma. This test is a screening test that supports early recognition and referral. It is not going to replace the general test done for these disorders, but it can help us to recognize patients early. As I said, 3 years for patients with hypogammaglobulinemia and 15 months for patients with multiple myeloma, as it has been demonstrated. So it can shorten diagnostic delay, identify patients needing immunoglobulin therapy or hemato-oncology referral, avoiding complications, and allowing an early start of treatment that can many times improve the prognosis of these patients. It has to be integrated into a standard lab interpretation, and this can improve early diagnosis. And it really doesn't take much. As I said, it is there. So also, this data supports the policy to retain the total protein in the LFT profiles of the biochemistry lab and educate clinicians about the use of calculated globulin, and really teach them to look at it and consider these possibilities when they are evaluating patients. As a recommendation, we should review the calculated globulin in every LFT panel and really consider if it's low or if it's high to test for hypogammaglobulinemia or for other types of gammopathies. Low calculated globulin in patients with infections should always be referred. So we can consider it also in the outpatient setting, but if patients have infections, they should always be referred. So a low calculated globulin should at least prompt the physician to ask for infections in that patient. Um, because it has been demonstrated as a very good early biomarker, it should be embedded in lab protocols for early patient referral. And this is really what we have to do. One thing to do could also be that we could do reflex IgG testing for every calculated globulin below 18 grams per liter or over 45 grams per liter. This is up to each country and healthcare setting to decide, but this is something that could be done. So with that, I am open to the discussion with Dr. Jolles. Thank you.
Okay. Thank you so much, Dr. Poli, for sharing your experience and also your insights.
Okay, so maybe I could start. Thank you very much, first of all, Cecilia, for this very comprehensive review of the publications, the data that is already available, and also your data that you shared with us. Thank you so much. So, as you mentioned, it is not a diagnostic tests. I think it's very important for the whole community to understand that it's rather an indication of some abnormalities, either on the hypogamma side, as you mentioned, obviously, which is of interest to us as per the primary immunodeficiencies, but also the secondary immunodeficiencies. But also, interestingly as well, to point to some hemonc issue like multiple myeloma. So, because, as you mentioned, it can affect a significant amount of patients, and that if you look back a few years before the test was done, we could one could have already pinpoint that this or this patient might have an immune deficiency. W- What is your take on the fact that it is not yet systematically available on every, let's say, lab report whenever the total proteinemia and albuminemia is uh, has been, measured?
I think this is a very important thing that you're pointing out to Nizar, because it is really available. So I think there needs to be more education to the medical community of the utility of this test. Because, for instance, in Chile, we have it, the calculated globulin is informed, which is one step forward than other places or countries or healthcare settings where it can be calculated, but it's not informed. So the first step, I think, is to motivate labs to at least inform it, and then uh, teach the medical community about its importance. Uh, when you see, a high ESR, I mean, that points to some diseases. So the same with calculated globulin, it points to some disorders that should be considered and tested. I honestly think everyone should have it in their labs, and we should do perhaps a better job in the medical community, educating them to really look at it and and um, help them be aware of the considerations that they should have when they see a low calculated globulin or a high calculated globulin. What we're trying to do, because it's impossible to teach all the medical community at once in a short time period, we're trying to validate this at least in our system, and flag it. So if you have a low calculated globulin below 18 grams per deciliter or over 35, we're going to put a note and say your patient may be at risk of of hypogammaglobulinemia or paraproteinemia. Please test it. And I think while we educate the community, putting notes like that may help. As I said, I think the data is there. It's been widely validated in different settings, different countries, different continents. Um, I think it should just be implemented.
Martine, do you have any question? Otherwise, I can continue.
As I'm representing the patient, I have a very lay question. When we addressed at first the warning signs for a PID, for example, we remarked that it was not easy for the physician to know what kind of exam should follow on a positive case, let's say, or how would you consider, because you spoke about IG level, is there, what do you think of vaccine response? I can see in the audience that we have people coming also from developing countries, and that would also very be helpful to have cheaper ways to establish the diagnosis after that. And my second point would be, how do you differentiate IgA deficiency who are asymptomatic from the others who need treatment and follow up?
Thanks, Martine. Those are both very good questions. I think the first screening, the first test that should be done when we have a low calculated globulin is the determination of the three, IgG, IgA, and IgM. And that way you can detect the patients with hypogammaglobulinemia, and you can also detect those with a low IgA and normal IgG that may be asymptomatic, and then you can advise them appropriately. But this test, which is relatively simple, available in most places, and it's relatively cheap, will allow you to make a diagnosis in most of the patients, at least of hypogammaglobulinemia or low IgA. Then you can, of course, go more profound on the diagnosis. If the patient has hypogammaglobulinemia, you are going to need the lymphocyte subpopulations or genetic testing or whatever comes after that, depending on the symptoms of the patient, etc. But with the quantification of all immunoglobulins, you should be fine at least to make a diagnosis, and this would immediately prompt therapy, because if you detect a low IgG level and the patient is having infections, this patient should immediately be referred to receive a gamma globulin replacement, even while you test the rest of the immune system or do the genetics or things more complicated.
Mm. We have quite many questions in the chat, and I will take some of them in a bulk. Can this test detect the problem before the patient has frequent infections? And a following question would be, when would this test be used by the family doctor, for example? And I see that why isn't it implemented everywhere? So maybe we can have a bulk of answer there.
Yes, yes, yes. Thank you. Well, so as we touched upon when Nizar asked, I think it should be implemented everywhere. I think physicians should be looking at it. It definitely can detect patients before they're having infections. I think particularly in the group of patients with CDID and secondary immunodeficiency, because these are patients that have received immunosuppressive therapy that may not have infections at the beginning until they have an IgG level of 200 or even 100. And if you detect a low calculated globulin before that, and therefore hypogammaglobulinemia before that, you can at least monitor these patients and intervene before they start having infections. And we have to remember that one infection may mean a severe complication, such as an abscess, bronchiectasis, or other complications that are going to in have implications in the future of this patient, and not only in an acute infection setting. So I think I didn't miss any of your questions.
No, I think it's very good, very fine. We have also a question about the result of that. Do you see or do you have any data showing the increase in diagnosis or treatment rates after the implementation of this test, and especially in Chile, maybe?
So I think Dr. Jolles' data there is fantastic. So patients have been identified in all of these cohorts that have implemented or validated calculated globulin ever since 2014, when Dr. Jolles published his work, and then thereafter in where people have done it in Brazil and other parts of Europe and in the US. Patients have been detected and referred for treatment and treated. So I think this is a reality, and that it's very well validated, and we should use it as a screening test. There may be, as I showed, I think looking at that curve that I showed is very important. So there is a spread. There's going to be patients that have a low calculated globulin but have normal IgG levels. And those patients, okay, they're tested. If they don't have infections, they're fine. But we have to remember that a great percentage of these patients that have low calculated globulin, especially if it's sustained in time, are going to have hypogammaglobulinemia and will need treatment for that. So it's a good screening test. As Nizar stressed at the beginning, this is not a diagnostic test, and it does not replace any diagnostic test. It also does not replace the evaluation by an immunologist or referral. If a patient is having infections and has a normal calculated globulin, it should probably still be referred to the immunologist for further workup.
Yeah, I want to stress the fact that as you mentioned, a normal calculated globulin does not rule out
Yeah.
an immune deficiency and a hypogammaglobulinemia, as you, I think, absolutely critically mentioned it. If, as a physician or a nurse or even a patient, you have the feeling that the clinical symptoms that one might have, is compatible with an immune deficiency, then even if the CG falls in the normal range, please do the diagnostic tests, IgG, IgM, and others, depending on the clinical symptom. But I think now Stephen is back with us, I think,
Not sure.
or not sure. He has a very unstable internet connection.
Please.
Um,
I was wondering about the labs. Is there a variability in total protein and albumin assays across labs? Do you have any idea on that?
And I don't know precisely, but so there is variability because they can be detected by these two different methods: the bromocresol and green, and the bromocresol purple, I think it is. So there's going to be variability between those two techniques. And this is why the threshold for calculated globulin is different between one and the other method. And this can vary from lab to lab. So it's very important to know what your lab is using. And therefore, that will help you identify your own cutoff level. That is why the calculated globulin is different. It's because the detection for the albumin has different methods. And I'm only aware of those two. So there's not a huge variability as long as you're using one or the other method and you know which method you're using. The cutoff levels will be different, but just that. And if we look at the data from different countries and different labs, because all this data from different countries have been done in multiple centers across each one of the countries, there's not a lot of variability in the levels of calculated globulin.
I think Leire asked, I think, a very interesting question, which is, can calculated globulin be used to diagnose other DIDs or SIDs that are not just, antibody deficiency? I want to stress the fact that the measurement of the Ig or the surrogate marker of Ig, which is the calculated globulin, will help identify patients with hypogammaglobulinemia or A-gamma. But these patients might not fall into the category of a B-cell deficiency such as a CVID, but might also have a combined immune deficiency, because in many instances, these patients with a combined immune deficiencies, which are basically T-cell related issues, can come with issues in the amount of IgG plasma levels. So it's a little bit of a nuance here that I want to bring. So you can diagnose a patient with a RAG1 or RAG2 or other forms of combined immune deficiencies, and not only, let's say, CVID or all the forms of antibody deficiencies. Cecilia, you're back. So I took over a little bit while you were trying to connect again. Just mentioning that at the end, when we diagnose a patient with a primary immune deficiency, he or she might not only fall in the category of B-cell defect, but can also fall into the category of T-cell defect with issues in amount of immunoglobulin production.
Exactly. That is very important. We have to remember that T cells and B cells have to interact so that we can generate appropriate antibodies. So if we have a T cell defect, we may also have a hypogammaglobulinemia. So yeah, this is a very important point as well. And as I said, so the first test you would do is immunoglobulin levels, but then depending on the symptoms of the patient, we should also test the whole immune system appropriately, and refer the patient for immunologic evaluation with the immunologist to decide which tests to do and how to interpret them. But in a primary healthcare setting, I think sending the patient with the immunoglobulin levels to the immunologist would be the appropriate thing to do.
How can who can we, as let's say immunodeficiency experts, uh, try to spread the good word within the doctors community, even reaching the very local hospitals or lab test, lab facilities, or even the GPs. Do you think we should um, build a strong case for calculated globulin to be used worldwide, especially as you, I think, very eloquently and elegantly mentioned it, it is very useful in low and middle income countries.
Because of the cost.
I think it's very good. I think it would be a good idea to um, publish a practice parameter or a statement so that that could be implemented worldwide. I think giving talks in not in our conferences, but in the general pediatric conferences, in other conferences where general doctors attend, is also very useful. I think if we have, so for instance, I have in Chile, and I'm sure part of your group has in France or other countries, any incidents on what the government is doing and government policies, giving our opinion there is also very valuable. For instance, we wrote the the protocols for immune deficient patients, so putting in there a statement about low calculated globulin is also useful. So I think we have to use all of the methods of communication, publication in the right journals, because if we always publish in the journal that only we read, that's not gonna get the message across. It has to be in a journal that the people that we want to get to are reading, giving talks, and trying to set these ideas and um, show people the data in our local governments and administrations to be able to implement this change. I don't think it's an expensive change. Also, I did see a lot of papers talking about um, the economics consequences of making a late diagnosis, but there are publications not related to calculated globulin, but there are several publications talking about the economical consequences of making a late diagnosis in patients with primary immune deficiency and also secondary immune deficiency. So I think there is a very important there is very important data to be considered as key elements in the decision of putting calculated globulin as a screening test and really looking at it and paying the attention that it deserves. I think I mean, I'm sure if we tell a government, okay, we're gonna make the diagnosis 3 years earlier and avoid these complications, and we count how many days missed of work or how many hospitalizations these patients had in this 3 or 4 year period, I mean, it's going to be cost effective to implement it, especially because it doesn't add any cost.
Uh-huh. I just have a question now about your own journey to come to that. Cecilia, how did you come to that yourself and to implement that in Chile?
So doing the actually, if I had the power to say, okay, we're going to implement it, and it's going to come in as a note in the report, and we're just going to do it, that would be the best. Unfortunately, we cannot do that, and we need to go through a validation process, uh, which is what we're doing now, and then to convince the people to really put it as a note and everything. So it has been complicated in the sense that to do the validation, we need to, have an IRB approval. And because we cannot consent each patient that has the calculated globulin done, we had to only take patients that also had a tube where we could test the immunoglobulin levels. So this has been the most complicated part, the validation, because it requires IRB approval. And then what do you do when you detect a low IgG levels? How do you contact a patient that has not been consented? All of this thing makes it a little bit slower. But if one didn't need local validation and we say, okay, there is enough data everywhere. And I think when this data from LabCorp is published, I think that is going to be making a big change, because it's 28,000 samples, and only they can do that because they test so many people in the US and have access to all of this data, which is very valuable to really prove, okay, this is a valuable lab test, everyone should implement it. So I think once LabCorp data is published, this is going to facilitate implementation everywhere, because it's not an issue of validating locally anymore, it's an issue of just implementing a test. And this is what is done with many other tests that come along, right? The cytokine levels or what have you. People just publish it and then they're implemented elsewhere. So I don't see why this should take longer for a test that we are already doing. I just want to stress the fact that we're already detecting total protein levels and albumin.
We also have a question from Professor Shin from Cambodia. In the countries where the prevalence of hemoglobinopathies is high, CG may affect the screening? Question.
I think yes. I think this is one of the issues that may affect the screening. And then, but again, if you're always going to detect some patients, and you have to, when you do it locally, then you will say, okay, this is the patients that we are screening, and you may be able to find other patients with hemoglobinopathies also using this same screening. So I don't think this is a barrier to implement it. It is just something to be aware of and monitor locally.
Mhm. And Dr. Jolles raises a question. Is there sorry, I can't read it because is there a role, especially in primary care, where the physician may be less familiar with calculated globulins, with PID? Sorry.
Yeah, I think definitely there's a role. We have to educate doctors in primary care, and because again, they have it in their LFTs or biochemistry profiles. Um, I think there needs to be a push in those places where it's not informed, because it just makes it easier, right? If you're in primary care and have to see, I don't know, 10 patients in a morning and are going to have to do, it's a small calculation. We do it all the time for creatinine levels. I mean, we do all these sorts of calculations. I don't think it's a problem, but if it could come as a no, like just as any other determination, there, I think that makes it easier. Again, I think we have to educate primary care doctors to look at it, calculate it. If it's not there, it's a very easy calculation, and at least have this prompt a question about infections in patients.
Can I ask you, Cecilia? I think we have a few minutes left, but I mean, we already have the protein electrophoresis. Why don't we use it rather than doing this calculation with and finding these cutoff values?
Well, I think protein electrophoresis is great also, and actually hypogammaglobulinemia detected by calculated globulin and electrophoresis, they're comparable to detect low IgG levels, but that is another test, right? You have to order the protein electrophoresis separately, whereas LFTs and biochemistry panels we're getting all the time as a screening in all patients. We don't screen patients with with protein electrophoresis. And to be honest, if we're going to do that, I would rather do the immunoglobulin levels as a whole, because it's also another test. I don't. It's more specific. It is the test that makes the diagnosis. So if we're gonna have to order an additional test, then let's order the most appropriate one. So this is why I don't think the protein electrophoresis, although useful, and if we do it and detect a low gamma fraction there, we can detect a patient with hypogammaglobulinemia. This is not a test that we're doing to every person that comes in for their yearly checkup, whereas LFTs and biochemistry panels, we are doing it as a regular. We don't need to implement anything. We just need to use what we have.
Maybe short question is, so you implemented it in your center, and you showed us the data. Um, could you let us know what was your journey?
So first of all, we talking to Dr. Jolles a few years back, we decided this was so simple that we should implement it. In our system, the calculated globulin was already, put there in before we even started doing this. The calculated globulin was already uh, stated in the results of the patients. So we just had to validate the cutoff levels for our population. We made sure that we were using the Romocresol green. So then we decided, okay, we will use 1.8 as a cutoff level, or 18. Um, and then the longest journey was with the IRB, because we were going to be doing IgG levels and protein electrophoresis in patients that had not consented for us to do this testing. So we decided to prompt this as a laboratory improvement test. So we said, okay, as a laboratory improvement test, because we want to flag all these patients that are having low calculated globulin. And in fact, we want to go further and flag all patients with high calculated globulin as well, because now, so we implemented a script for the lab, so that it automatically warns, or it sends us a list of all the patients with low calculated globulin every day, so we can screen those patients to do the immunoglobulin levels. So because we have this script already written and embedded in the computer system of our laboratory system, we can just change the number and say, okay, now do it for the greater than 35, and just give us the list every morning. And so every morning we get a list of the patients with a calculated globulin below 18. And then we see, okay, do these patients have a serum tube where we can test the immunoglobulin levels? And we do so. Because of the variability in the patients below 1 year of age, we decided for now to leave those patients out of the study, which most of the patients that are below 18 are younger than a year of age for obvious reasons. So that has made it a little bit slower for us to detect patients, because not a lot of patients have, as you could see, we screened 30,000 patients, and we only had 260 something patients with a low calculated globulin. So there's not a lot of patients. So we have to, wait a little bit more to have a greater number of patients in which we can validate it. But the data is looking great so far, very much along with what has already been published.
Mhm.
Thank you.
I think that we come to the end of our hard talks, and I want to thank you, Dr. Poli, for your very interesting talk. Thank also Nizar for the interesting conversation on clinical application and calculated globulin screening. And of course to Professor Jolles for inspiring and preparing this important topic. We will now also share a short feedback form which should pop up on your screen. It's very useful for us to know your feedback and to hear your comments to continue to improve this concept. Thanks again to all of you for attending this new edition of IPOPI Hard Talks. In a few days, you will be able to watch it on IPOPI YouTube channel. Don't hesitate to share it as much as you can. And many thanks once again to everyone who joined us today. And a special thank you, of course, to our sponsor, CSL Behring, for making this possible. To our audience, stay tuned for the next edition of IPOPI Hard Talk. We look forward to welcoming you again soon. Thank you and see you next time.